Get started. So we're talking about GI meds. I'm sure you've already talked about GI stuff in your medicine course already. So you've probably heard of a lot of these drugs already. We'll talk about them from our standpoint here. What is GERD? When you hear GERD, what does that mean to you? So, acid reflux. Why do you have acid reflux? What does that happen? The lower esophageal sphincter tone is maybe a little low, right? Can medications affect that? Yeah, I remember we were talking about calcium channel blockers. GERD can be one of those symptoms you get from that, because remember that it can inhibit that smooth muscle, and that can include your GI tract, so that can happen there. You find a lot of different medications can actually worsen someone's GERD, so that's something to always consider. Say, what new medications have they started? What changes have they made? What other things typically cause a GERD? Caffeine can do it, so I'm sure most of you may experience some of that if you're particularly sensitive to it. What else? Alcohol, spicy food, yeah, so lots of different things are going to be seen here. And so you're going to find that some patients are going to have more sort of episodic episodes. Episodic episodes sounds a little redundant, but they'll have episodic instances of GERD. Some of it is going to be a little bit more chronic depending on kind of what the underlying pathophysiology is. If you go out and you eat that third plate at your favorite Chinese buffet, that's going to be more of a real kind of intermittent sort of thing there, versus if it's due to medication causing an issue, or if it's due to some sort of anatomic issue, that's going to be more long-standing there. But we do know we're having this retrograde movement of contents from the stomach, so a lot of this is pretty caustic, right? A lot of that HCl and pepsin and things like that will then eventually erode and degrade the esophagus. And why do we care about this long-term? Cancer is obviously the big one, right? But what could you have? Maybe what's more like life-threatening in the immediate sense? You have bleeds, you have perforations, right? So those are the things you'd also be kind of worried about for more severe cases, more acutely. And so, again, as you mentioned here, there's a lot of different things that happen here, especially in little kids. They can have anatomical issues. Sometimes they need surgery in order to fix this, to where they're not going to have such bad reflux for those patients there. But we also want to look at the composition of the refluxate. So basically, what is the composition of the contents coming back out? And that we can affect with our medications, as we'll see here in just a little bit. So looking at this, it looks a little complicated, but we'll kind of work through it. So if you imagine here's your paracrine cells. This is kind of along the lining of the stomach here. Here's going to be the luminal side. Here's the basal side here with the bloodstream. The parietal cells, what do parietal cells do for us? Yeah, so they're actually producing the HCl that's going to be making up the contents of the stomach. Now, what is the normal pH of the stomach? Around 2, right? So pretty acidic, right? So we can find medications that will affect that. I want you to focus on a couple different things here that are going to be important for this. One, look at the different sort of hormonal factors that will stimulate release from the parietal cells. So you're going to have things here like acetylcholine, right? Now, why do you think acetylcholine is important in terms of activity in the GI tract? What kind of receptors is it hitting in the GI tract? Muscarinic, right, because it's part of that rest and digest system, right? So you're going to find that acetylcholine will stimulate activity of the GI tract. And similarly, you're going to find they have anticholinergics that cause diarrhea or constipation. Constipation, right? Because again, you're inhibiting peristalsis, you're inhibiting activity of the GI tract with an anticholinergic. So similarly, here by stimulating these muscarinic receptors, acetylcholine will cause increase in your acid production there, right? Histamine is another big one as well, right? So you're going to find that we'll look at our H2 blockers a little bit later, see how those are going to affect things. And you have prostaglandin. This is actually an important thing here. Notice it has an inhibitory effect on production of acids. Now, prostaglandins are mainly affected by what class of drugs that we've talked about kind of all semester? NSAIDs, and then what else could affect it as well? Aspirin, right? So again, going along with the NSAIDs, what else? Remember, corticosteroids can do this as well. Remember, corticosteroids are just working kind of one step higher in the process than the NSAIDs are. And so if you have a lot of corticosteroids on board, you're producing less prostaglandins. What does that do to the stomach? So we'll talk about protective barrier in a little bit, but you also end up seeing increased HCl production there as well. And again, when people are chronically stressed, as in your first year of PA school, you can develop things like stress ulcers in the stomach because you're having these effects from the corticosteroids you're producing, the cortisol that you're producing. But you also see it if you're giving it to patients exogenously for autoimmune conditions and things like that. So prostaglandins are really important here. Gastrin, we know, is going to have a positive effect here. And then basically you're going to find this proton pump is what's kind of causing the HCl to be produced here, okay? So it's going to be spitting out the HCl. and that's what's causing that acidity. That's what's keeping the pH around 2. And then when you reflux that, the esophagus isn't really well equipped to handle that reflux, and that's why you end up getting those symptoms you see with that. Now, looking at the epithelial cells here, this is important for the protective barrier. Yes, ma'am.
So the prostaglandins stop the HCl from being produced?
They inhibit the HCl production.
So that would cause... Oh, okay.
Got it. So anyway, so looking at the epithelial cells, you're going to find that, yeah, while the gastric lumen is around a pH of 2, the actual mucus barrier along the lining of the stomach is going to be around a pH of 7, so much more, much more neutral, and you're going to find that is basically what prevents us from digesting our own stomach, as you're going to see there. So prostaglandins will have another big stimulation on these cells. Muscarinic receptors will have a big stimulation here. That's what's going to produce the mucus, and then the bicarb, right? So the bicarb is a really important component of there. That's what's going to be neutralizing a lot of that stomach acid. Again, so when you find patients who are either chronically stressed or if they are receiving exogenous corticosteroids, you're going to see this here where the lack of prostaglandins is going to decrease the barrier. It's also going to decrease, or actually cause an increase in the amount of HCl being produced. That's why you end up seeing these peptic ulcers that develop there, right? That was one of the biggest reasons why people develop peptic ulcers. That's a big one. How about medication related? NSAIDs are the biggest one, right? So again, anytime patients coming in complaining of stomach complaints, like ask them about their NSAID use, because again, if you ask them, hey, what medications do you take? They may only think prescriptions. You may not think about the over-the-counter stuff that they're taking as well, unless you ask. Okay, so we know there's a lot of risk factors associated with this. Certainly, like pregnancy is a big one, and you want to think about that in terms of medications that they can be exposed to, because in general, for pregnant patients, what's the ideal number of drugs they should be on? None, right, ideally. But look at other things, some of the behavioral factors there. So if they notice, wow, whenever I go out drinking, I get really bad GERD, what do you tell them to do? Stop drinking, right? So some of those they'll follow, some of them they may not, depending on the situation there. Okay, so and there's a lot of foods that are going to be associated with this. So of course, all the good stuff in life. All can cause GERD, unfortunately. But I want to focus more on the medication side of things. So again, things that are decreasing peristalsis, or things that are decreasing the tension of that lower esophageal sphincter. If that tone goes down, you're going to see reflux happening here. So you see a lot of calcium channel blockers, narcotics, anticholinergics. Think about nitrates, right? We talked about nitrates and angina. They're smooth muscle relaxers. They can do the same thing here as well. A couple other drugs we'll talk about. So we'll talk about bisphosphonates. Does anyone know what those are used for? Yeah, we use them for osteoporosis. We'll talk about that next semester, but that's another big one that can cause GERD symptoms. But a lot of iron and potassium salt supplements can also be really prone to doing this. And then obviously we mentioned the NSAIDs being another big risk factor here as well. So a lot of medications. Make sure you go through and do a good medication history to see if anything could be contributing here. So what are our goals here? Obviously, we want to alleviate or eliminate symptoms, and if we can try to decrease the number of episodes they're having, that's going to be beneficial to them. And assuming that if they have any severe injury done to the esophagus, you want to be able to allow that tissue to heal and to rest, so to speak, so that way you can go ahead and eventually not turn cancerous, hopefully, and prevent any sort of life-threatening complications like perforations, bleeds, etc. So what are our options here? Obviously, as I mentioned, lifestyle modifications are important, but patients may or may not be super jazzed about saying, hey, you can't eat this stuff anymore, or you shouldn't be drinking this anymore. They say, well, I'm going to do what I want to do, right? Well, let's look at the pharmacologic interventions, the things that we can do for those patients there. Obviously, there are certain things you could do in terms of like surgery, but I'm not going to get real deep into that because it's just not my wheelhouse, right? Certainly things like losing weight, elevating the head of the bed, all those things can kind of help out with that. Smoking cessation can be a really big one. Smoking tends to cause some relaxation at lower esophageal sphincter as well. Tight-fitting clothing, alcohol, all those things there are really, really important for those patients. But let's look at our pharma options. So we'll break them down into these separate categories here. So we're going to find that we'll have our antacids. We'll talk about H2 receptor antagonists, proton pump inhibitors, prokinetics, and the mucosal protectants. Those are the main groups here of medications you're going to see being used in GERD. So basically, there's 3 different ways we can attack the problem here, right? And you'll find that this just doesn't cover GERD, but it covers all sort of spectrum of disease related to hypersecretory conditions and all these different things that are affecting the GI tract. If it has to do with stomach acid being a problem, these medications are going to get used for all of these things. So I kind of house it all within the GERD topic, but they can be used for lots of different purposes. So we can either neutralize any excess acid that's already produced, we can reduce the amount of acid that's being produced, or we can try to enhance the mucosal defense. Okay, so those are kind of the three ways we can do that. Some drugs will provide benefits for multiples of these. Some of them only work for one situation. We'll look at the mechanism and why that is. So in terms of neutralizing excess acid, that's where we're going to use an antacid, right? So basically giving them some sort of salt that will help to neutralize that HCl. Okay, we'll talk about different ways that happens there. There's a couple different preparations that we'll look at here, and so you're going to find they may have different neutralizing capacities. Some may be a little bit better than others. They may have differing solubilities, and palatability can be another big thing as well. So looking at this, we have a couple of different ones that are here. So going back to your kind of basic chemistry, hopefully this doesn't scare anyone looking at equations. But for instance here, what is this molecule? Sodium bicarb, perfect. So sodium bicarb, we can just give baking soda, right? Baking soda plus hydrochloric acid produces salt and water and CO2. What do you think all that CO2 does? Yeah, so it can cause abdominal distension, it can cause burping, cause flatulence. So again, the gas production can be a side effect of these medications as well. Other common ones you're going to run into include, anyone know what this is? Good, calcium carbonate. Another name for that is what? Tums, good. This is going to be the most common one you're probably going to run into for the most part. How about this drug here? What is that? Aluminum hydroxide, good. And then we have magnesium hydroxide. Very good. I'm just testing to see if you remember your periodic table of elements, right? Anyway, so you're going to find they're all kind of basically doing the same thing. You may find that certain ones don't produce as much CO2. So for instance, aluminum and magnesium hydroxide, usually you'll find these two put together in a product called Mylanta or Malox. You find these two put together, they don't produce as much of that carbon dioxide, so you may not get as much, flatulence and abdominal distension. Anyone know the scientific name for burping? Eructation, if you've ever heard that. It's a fancy term you can wow your friends with, right? But anyway, let's talk about the different agents here we have available to us. So we have sodium bicarbs, is going to be the first one. Quickly will neutralize the acid. Now, when do you think you'd want to take an antacid? Do you think you'd want to take it, say, around the clock? Do you think you'd want to take it sort of episodically? When do you want to do it? Yeah, so if they can anticipate if they're going to have symptoms, they can take it beforehand. Because again, when does your stomach sort of start producing that stomach acid? Actually starts a little bit before you. If you recall, if you go back to your physiology, there's several different phases of it. So for instance, like when you see a big juicy hamburger, if you're so inclined to like hamburgers, what do you start to notice? Your mouth starts to water. Your stomach's already producing some of that acid as well, right? So again, if you can take it beforehand, before the patient, if they know something's going to trigger them, then they can go ahead and have that beforehand, and that can be beneficial. Otherwise, they'll frequently be taking it once they develop the symptoms. They may be taking a Tums after their meal or with their meal potentially. However, what can be some problems, do you think, with certain patients in getting sodium bicarb? Not constipation so much. What about that sodium? Who's that sodium not good for? Causes water retention, right? The more sodium you absorb, the more water you're going to hold on to. Who's that bad for? Heart failure, hypertension, yeah. So if they have liver failure, ascites, like all that can exacerbate those problems there. So another thing as well, if you think about like pregnant patients, do they have any issues of fluid retention? Yes, they have a lot of extra blood volume, especially later on towards the end of pregnancy. They get very swollen, especially like in their ankles and things like that. So yes, absolutely, you gotta be careful with that. And then the other thing to consider as well with the antacids is they're sort of self-limiting, because once the stomach detects that the pH is too elevated, what does it want to do? Well, it wants to get back to homeostasis, right? So it says, well, my pH is too high. I need to increase the gastrin release to try to get that pH back down by releasing more HCl. So you'll find that these are going to be good for sort of intermittent treatment of GERD symptoms, but they're not good for like long-term or prophylaxis of those symptoms there, right? So that's one of the big things to know with the antacids. Calcium carbonate, again, works very quickly. You're going to find that you will absorb some of that calcium there. Calcium actually gets absorbed better in more acidic mediums. But in this case here, you'll have some of that calcium being absorbed, which could be good for certain patients, right? So if you have issues of osteoporosis, that may be a good thing, right? However, you can find this maybe not great for certain patients. So for instance, if the pH in the kidneys rises too much because of excess calcium carbonate absorption, you may find that kidney stones can develop, right? Well, actually, calcium will cause it to precipitate out, so that's one thing you want to know. And again, you will see that rebound acid secretion. Calcium, though, is a big one that's going to cause decrease in peristalsis. That's where you can see constipation. So calcium-containing products, very notorious for causing constipation. That will not always be the case. You'll find some of these are better for causing diarrhea, as we'll see in a little bit. We have aluminum hydroxide. So sometimes this is actually being given for renal patients. So we'll talk about this next semester, but this is actually something that will bind up phosphates. And so phosphate is a big issue for chronic kidney disease patients. They tend to develop a buildup of that. So you may see it used by itself for chronic kidney disease patients, or you may see it used in combination with something like a magnesium hydroxide. But it's in and of itself, you're going to find that it has a nice cytoprotective effect on the mucosa, which can also be beneficial. This will cause constipation, and it can chelate with other drugs. So you got to be really careful about giving these antacids along the same time as other medications, because they tend to bind up in those cases there. Okay. Now, aluminum itself, do you think, what's like a normal aluminum level in a patient? Should be 0, right? It's not like a naturally occurring substance in our body here. So, and actually for some of these kidney patients who can't really process and clear that aluminum, we were finding they actually develop neurotoxicity from this. Shouldn't be a big deal if you're taking it for just episodic GERD symptoms, but just one thing to kind of consider. Magnesium hydroxide is the other side of that. So milk of magnesia is when it's by itself. You may hear it called that if you ever see like MOM, M-O-M, milk of magnesia, what that is referring to. You're going to find this actually causes diarrhea. So mixing this with aluminum hydroxide actually kind of balances each other out a little bit from that standpoint. But frequently we'll give mag hydroxide as basically as a cathartic, something to try to increase peristalsis. If patients are constipated, we'll talk about that a little bit later there. But certainly be careful in patients with like renal failure, because they tend to hold on to that magnesium. They can have hypermagnesemia, and if they have things like intestinal obstruction, that diarrheal sort of effect can be kind of an issue there, causing blockage potentially. As I mentioned, combine these two together, so Mylanta, Maalox, actually tend to find that used together actually kind of counteracts that GI motility, which can be beneficial because you don't get that constipating effect. You shouldn't get the diarrheal effect. You should be kind of balancing each other out in that case there. Now, what do you think in terms of dosage forms? Which one do you think is a little bit quicker acting, liquids or tablets? Yeah, liquids typically, right? Because again, they're already in solution. They're already going to be able to mix directly with that HCl and neutralize it. However, may not be palatable to certain patients, so it may be something to consider. Tablets may be a better option for them, though. So, now, do you need a prescription for any of these antacids? You don't. You can get any of them over the counter. And so, what could be a danger of that? Patients are self-treating themselves. They could have something kind of more serious going on there, right? So maybe that nagging feeling they're getting could be related to, say, a peptic ulcer is developing, right? And they're self-treating it, they're masking the symptoms, not realizing things are getting worse for them. So you gotta be really careful from that standpoint. Again, typically if you look on the boxes, they'll recommend no longer than, say, like 2 weeks of treatment, because at that point, if you're still having symptoms, you probably need to get something checked out, and you probably need to go see a provider. Typically, these are safe in pregnant patients, because again, most of them are just electrolytes. Most of them you're gonna find don't have really great absorption there. However, we mentioned sodium bicarb is an issue for those patients. Again, for pregnant patients, they develop a lot of that fluid retention that can increase their blood pressure. And what do you call that when patients are hypertensive in pregnancy? Preeclampsia, right? That can be a big issue for them as well. And of course, as I mentioned, drug interactions, be careful, because these will bind up things like tetracyclines, iron products, fluoroquinolones. You got to separate these out. Either take these medications an hour before the antacid or like 3 to 4 hours afterwards. Okay. So the advantages here, they're very rapid in terms of their effects. So again, you could take it as sort of rescue therapy, so to speak, once they're developing symptoms. They're inexpensive, they're over the counter, they're better for sort of breakthrough sort of symptoms, right? When you say breakthrough, what does that mean? Yeah, kind of as it's happening, right? So say, for instance, I was taking another medication around the clock, but I had something that really just sort of set my GERD off. That's kind of breakthrough symptoms, right? And so that's where an antacid can be very useful there. So usually these are kind of as needed medications. These are not effective for healing. So if you have any sort of esophageal damage or gastric damage is already done, these don't inhibit acid production sufficiently, because remember we said they actually cause rebound acid secretion, to allow for that healing there. Right. Also, we notice the constipating or diarrheal effects, the potential drug interactions. So there are some drawbacks to these. But again, for sort of minor, just run-of-the-mill GERD symptoms every once in a while. So you had Thanksgiving dinner, you overate, had a little bit of GERD. These are perfect for that sort of situation. Okay. So moving on, let's look at the next step in the chain here. What could we do in terms of reducing gastric acid secretion? And so here we're going to have a couple of different agents. Yes, ma'am. Not just causing it, but it could potentially worsen it. Again, it's not something that comes up super often, but it's like maybe if they're trying to treat stomach pain with that, it's one of those things where it's like, appendicitis is something like kind of needs to be evaluated right now, but if they're trying to take stuff to they just have stomach pain, like, oh, let me take a Tums or something. You know, it's one of those things where it's not gonna make it worse. It just may delay them actually getting treatment they need. Yeah. Okay. So getting into how to reduce the acid secretion. So you have a couple different ways we can do this, a couple different medications here. We'll talk first about the H2 receptor antagonists. Now we talked about H1 blockers. What do those do? For allergies, right? What else could you use them for? For sleep. Yeah, motion sickness, absolutely. For antiemetic actions. We'll talk about antiemetic actions in just a little bit, and motion sickness and whatnot. But yeah, so anyway, so H2 receptor antagonists are going to be on the opposite side of that, right? So they're working just on the H2 receptors. It's primarily just going to be in the stomach. And so by blocking these receptors here, you're going to find that it will decrease acid secretion pretty significantly. However, is this the only thing causing acid secretion? No, there's other pathways there, right? So you still have gastrin that can stimulate this. You still have acetylcholine that can stimulate that. So when compared to another class of drugs we'll talk about in a moment, these are not the most effective, but they're the oldest group we have in terms of decreasing acid secretion. They've been around for a long time. They have a pretty good proven track record, and for the most part, they're over the counter, they're cheap, so they still get used quite frequently. So you're going to find that we'll reduce the volume and the hydrogen ion concentrations, the pH should rise, and it's going to be reducing pepsin. This is kind of working more around the clock, right? So this is going to be better for patients who have more chronic GERD symptoms, or if they want to use something prophylactically. This is going to be the set of drugs to start out with in a lot of them. So a couple ones we have in this category. We have cimetidine, we have ranitidine, famotidine, and nizatidine. Those are the main ones you're going to find out there. Again, you can find them on any drug store counter. These are available over the counter. Many of these are available IV as well, so you'll find that if you're on the inpatient side, patients will get IV medications of H2 blockers sometimes. So they do require renal adjustment, though, so be aware of that. If you have patients with renal disease, you may have to adjust your doses a little bit. However, the toxicity is not really so significant with you. That's another benefit of these drugs here, is that they have very limited side effects for the most part. Now here, this is just things they list, but honestly, I can count them on zero hands the number of times I've seen any of these side effects actually occur, because we do use these drugs all the time for patients here. But things like CNS confusion, maybe thrombocytopenia, you know, a lot of these things just get listed in the package insert because it happened one time during the trial, and they have no idea if it's actually related to the drug or not, but it is what it is, right? So again, nothing real significant here from side effects to really worry about. We'll talk about some other things that can happen as a result of use of these drugs, but from a side effect profile, very well tolerated. So you're going to find they're pretty effective in, you know, about 2/3 of patients you're going to be treating for GERD symptoms. They are more effective than the antacids, right? Because again, they're not really self-limiting in their actions. With the antacids, you neutralize the acid, then the parietal cells want to send out more acid. Here, you're blocking that effect, and so you shouldn't really see that same issue there. Now, why you choose one over the other, most of the times it's going to be based off of what's available via the formulary. So for instance, at the Moores, we used IV ranitidine for years and years, and then it became cheaper to buy IV famotidine, so that's what we did. Switch over to famotidine, right? Again, because they're therapeutic equivalents, you can use either one of those. They're going to be all that effective. They're more expensive than antacids, so that's one drawback, and they're all are very safe in pregnancy, right? Ideally, no drug is the best number of drugs for pregnant patients, but if you need something, these may be safe in a lot of cases. Typically, you find dosing twice a day in order to kind of provide nice 24-hour coverage. For some patients, they have worsened symptoms at night when they're recumbent, and so that's why you end up dosing at nighttime in order to help cover for that time period there. Sometimes they'll take a PRN if they just know, hey, if I eat certain foods, it's going to trigger me off to go ahead and take it at that point. So it just really depends on the situation and how they're using it. Now, the one thing I'll say, the one H2 blocker you should never, ever recommend is cimetidine. The reason why we don't recommend that is because it's a very potent CYP3A4 inhibitor. Okay, so it's over the counter too. So I mean, patients could be taking this without you really having any knowledge of it unless you ask. Cause a huge number of drug interactions. So that's why I say there's no reason to recommend this one. I don't even know why it's still out there on the market, but it is, right? So definitely tell your patients, hey, if you need something for GERD symptoms, don't use this one, especially if they're on any other medications that could be interacting with it, okay? Cimetidine, yeah. Or Tagamet's the brand name there. Okay. So another way we could do things, so instead of worrying about, say, these different hormones that can stimulate secretion of the acid, why don't we just go to the pump itself? Why don't we just go to the actual means of production and stop that, right? And so you're going to find we have the proton pump inhibitors, the PPIs. These are the newer class of drugs to use for gastric acid secretion. And so them being newer, some of them are still brand name only, some of them are a little bit more expensive. This is probably the most expensive drugs out of the group we talked about so far. But what's nice here, they're irreversible inhibitors of proton pumps. So that means that once they're on board, that proton pump is basically non-functional until the cell replaces that, which means that it's very, very potent in decreasing acid production, right? So very, very good. And about you have 95% inhibition, after 7 days or so of therapy. So very, very good at what it does. The drugs in this category include esomeprazole, lansoprazole, omeprazole. So if you notice, esomeprazole and omeprazole are kind of, omeprazole is the racemic mixture, esomeprazole is the left-handed version. Then you have pantoprazole and rabeprazole. Okay, some of these are available over the counter. So for instance, you can get omeprazole pretty easy at the drugstore. But again, they can mask a lot of those symptoms if something more serious is going on. So make sure they're not using it for ages and ages. More than 2 weeks, they probably need to get checked out. So some of these they can find some risks. They do see some hyperplasia of the parietal cells in experimental models. Could that lead to cancer potentially? Who knows? We don't really know down the road. But one thing you will see is that by elevating that stomach acid, elevating the pH of the stomach contents, normally the stomach is at a pretty sterile area. Yeah, not a lot of stuff really grows in a pH of 2, right? Except for what bug likes to hang out in that environment. H. pylori, right? So assuming there's no H. pylori there, most of the time the stomach's going to be fairly sterile. Well, what happens if I decrease the amount of acid I'm producing, the pH increases? Bugs start to grow, right? And so this is something we'll find, especially in like really critically ill medical patients. So if you go over to the ICUs, you're going to find that stress ulcer prophylaxis is a really big thing that we consider for those patients, especially if they're on the ventilator and they've been in there for a couple of weeks. You worry about them being in a very highly stressed state. They're releasing a lot of cortisol. They're not really able to produce that gastric protective barrier there, and so you worry about them developing gastric ulcers. We know that's a risk seen with those really critically ill patients, and so we give them PPIs, right? Give them PPIs in order to help prevent that from occurring by decreasing the acid production. Well, then what happens? All those bacteria start to grow in the stomach. They just stay in the stomach? No, you can have these little micro aspirations that go up from the esophagus into the respiratory tract, and then guess what happens then? Now you have like ventilator-associated pneumonias that can happen in those patients there. So it's kind of a double-edged sword. We want to make sure the patient doesn't get further infections for the healthcare-associated infections, but we also don't want them to have that gastric ulcer that develops. So in those cases, there are things like good oral hygiene can be very beneficial to prevent that. There's different things we can do there. So those are some risks. Just be aware of that. Another thing as well is that calcium, as I mentioned, tends to get absorbed better in more acidic environments. And so if you don't have that acidic environment, calcium absorption is going to go down. And who might that be a problem for? Or elderly patients, right? Patients with osteoporosis, or maybe women who are hitting menopause where they're losing the estrogen effect and they're going to get osteoporosis potentially. They have decreased calcium absorption. It's going to be an issue, right? So again, it's more of a long-term sort of concern for these patients there by kind of chronically increasing the pH of the stomach. So we administer these around 30 minutes before meals, typically because they bind better to active pumps than they do to inactive pumps. And when do you think these pumps are most active? Around mealtime, absolutely, right? Because that's when you're going to need that acid to actually digest that food you're eating. Now, what's interesting is if you ever find one of these, most of them come in capsules, and you'll find there's like a lot of little beads inside of them. And so basically, the drug itself is not all that stable when it actually hits the stomach acid. It actually would degrade the drug. And so what we do instead is we actually put it in this nice little coating that is acid resistant, such that it will pass through the stomach where it's more acidic, and once it gets to the small intestine where pH increases pretty greatly, then at that point that coating will dissolve and then you can absorb the drug. So we tell them not to crush or chew it because that will then ruin that protective barrier and the drug won't work as well. Okay. Now, you're going to find that PPIs typically provide better healing for these patients here than the H2 blockers do. However, they tend to be a little bit more expensive, but just be aware of some of those trade-offs you get with that. Again, these are very well tolerated, not a ton of side effects unless I mention those kind of more specialized issues there in those critically ill patients or patients needing calcium absorption. And again, you can find issues of drugs not being absorbed as well, so things like iron salts, ketoconazole may have their absorption being decreased due to these changes in pH. A couple other drugs we have here include octreotide. Yes, ma'am. Yes. I'm just kidding. Go ahead. No.
And I just assume that the healing occurs because you're taking away the acid, so the damaged tissue is allowed to heal on its own.
Basically, yeah, especially if there's issues of, why was that tissue damaged in the first place, right? Is it because you've chronically been decreasing prostaglandin synthesis because you're taking NSAIDs all the time? That could be one thing. It could be because you have a hypersecretory disorder where the parietal cells are kind of working in overdrive, and now you're inhibiting that. So basically by decreasing the amount of stomach acid there, it's trying to eat away at that tissue, you allow it to heal. Mm-hmm.
So if they go on a regimen for a couple of weeks, they heal, and then they don't have a lifestyle change, and probably won't come right back.
Depending on what the cause for it was, right? So if it was H. pylori causing a gastric ulcer, and you don't eradicate that with antibiotics and bismuth and PPI, then yeah, it's gonna come right back, right? Or if it was because they were chronic drinkers, and that was leading to it, and they don't change that behavior, then yeah, that could lead back to it again. It depends on the situation. Okay, so this next one we have is octreotide or somatostatin, and so this is actually an analog of somatostatin, which is a natural product that we produce ourselves, and this actually blocks gastrin release. So this is another way to decrease the amount of gastric acids being produced by blocking the activities of gastrin there. Octreotide we use for several different things. So for instance, you may see it used for things like variceal bleeds, especially like in patients with hepatic failure. We'll give this, and that can actually help to constrict some of those variceal vessels. I use this sometimes for patients, we'll talk about diabetes next semester, but when they have a overdose of a certain type of anti-diabetic medication, we can actually give this in order to, as an antidote to treat that. But in terms of its activity in GI things, this is where it's working, is to block that gastrin release. And so you see this used for things like gastrinomas, if they're having Zollinger-Ellison, which is a hypersecretory disorder, things like that. This is parenteral only, right? So it's only going to be available IV. This is an inpatient sort of drug. They're not going to be using this on the outpatient side like they would a PPI or an H2 blocker. Okay, and then next we're going to look at our mucosal protecting agents here. And so we had things like colloidal bismuth or bismuth subsalicylate. So I'm sure most people have heard of or taken Pepto-Bismol at some point in their life. And I know my mom, whenever I was a kid growing up and I got sick, I always got Pepto-Bismol. It does not matter what I had wrong with me, Pepto-Bismol was always given to me. So, but anyway, so the nice thing here, it coats the stomach lining, and it has some nice cytoprotective features, right? So it can help with that that damaged tissue. And in fact, if you're looking at treatment for H. pylori, quite frequently bismuth products are going to be one of the components of that regimen there. It helps to inhibit pepsin activity. So again, all very beneficial for helping that tissue heal there. Couple things to note though, is that one, it can turn the stools sort of a black color. And why is that worrisome for a patient potentially? Because we're at upper GI bleed, which is perhaps what you're actually trying to treat in these cases here. So let them know that, hey, you may find it's a little bit darker, maybe black sort of colored. It's not the same thing as the actual upper GI bleed. They get that tarry sort of nature to the stool there. And also, it's bismuth subsalicylate, so it contains salicylates in there. So who is this not really great for? Kids less than 16, you worry about the Ray's syndrome risk there. In fact, one thing, if you ever know, if you have a patient who comes in, say you're working in the ER, and you have them, they come in for abdominal pain, and you do a KUB, and you see these little punctate marks kind of all over along the GI tract. First thing you want to ask them is, have they taken any Pepto-Bismol recently? And the reason for that is that bismuth will actually show up as radio-opaque, so you can actually see that on the KUB there. So you can look up pictures of that. It's kind of interesting if you ever see that. It's kind of an incidental sort of finding. Another drug we have here is called Carafate or sucralfate. This is basically this non-absorbable aluminum salt, and basically once it hits the acidic medium of the stomach, it forms this paste. It basically is just going to coat the stomach and protects it pretty well there. Typically, if it's used for GERD, it's only for very mild cases, or maybe if you don't want to use an H2 blocker or PPI. But we'll give this quite frequently for patients who maybe are more at risk for like stress ulcers and things like that. Typically, we'll give it before meals, so that way it's going to, when you have the most acid production actually happening there, we either have a liquid formulation or we actually have a large tablet patients can take. So if they can't handle that really big tablet, then we'll go ahead and just use a liquid formulation. All right. A couple other agents we have here. So one, we have misoprostol. So we mentioned that prostaglandins stimulate that protective barrier. Well, if you don't have prostaglandins, you can replace them. You can actually give a synthetic form. And so here we have one called misoprostol. It's a PGE1 analog and will help to stimulate that gastric barrier. And in fact, sometimes you'll find these co-formulated with certain NSAIDs. So if a patient needs to be on an NSAID chronically, you can actually formulate it with a prostaglandin analog and will help to prevent those NSAID-induced ulcers from actually occurring there. One thing to know here, though, is that this is actually going to be contraindicated in pregnancy. Does anyone know why that could be? stimulates contractions, and in fact, if you were to look at ways to actually induce chemical abortions, misoprostol is one of the ways you can do that. Sometimes they would actually give methotrexate plus misoprostol in order to cause a chemical abortion, so to speak. And in fact, when I was first interning at a hospital, it was actually at St. Vincent's up in Jacksonville. It's a Catholic institution, and they actually would not carry misoprostol because of the use as an abortive agent. They just didn't even carry it at all, which I thought was really kind of interesting. How you can find sometimes an organization's beliefs actually affecting the medications you carry potentially. So it's kind of interesting things there. But anyway, so we do use it sometimes for gastroprotective sort of features there. And in fact, though, we actually use prostaglandins. We actually use them for patients who need to actually have their babies, right? So we can actually use this, actually stimulate contractions potentially. And we'll talk about that when we get to OB-GYN next semester. Some of you guys will have me back next semester. I don't know if you guys want to fire me in the meantime, but anyway. I'm just kidding. You don't have that much power. But overall, looking at the overall efficacy, comparative efficacy, and drawbacks for these medications here. Again, antacids are going to be the easiest, quickest, but least effective overall versus your H2 blockers versus your PPIs here. Again, these tend to be more expensive. However, these are going to be, as far as efficacy goes, probably the most superior, especially if you take it chronically, take it consistently. They're going to have pretty good effects on decreasing the acid production. Okay. And so again, typically when you're doing GERD therapy, if you have a patient coming in, if it's their first time, if it's very sort of intermittent, again, you can start off with something like an antacid. That's perfectly reasonable. But as they progress, as things get more persistent, then you're going to kind of step up your game a little bit. So again, try off. I'd say just go with an H2 blocker first, see how that's going to work for your patients. If it's very severe though, PPIs are going to be where you want to go to for that patient. Okay. So again, obviously lifestyle changes are going to be recommended all the way throughout here, right? So again, that's always going to be the thing to really harp on for your patients, but again, whether or not they follow that is going to be questionable. But then if you have really refractory patients here, this is where interventional more therapies need to be looked at. So again, have patients talk with a gastroenterologist. They may need like an EGD done, they may need other things done than you would do from, say, from the primary care sort of perspective. A lot of patients, so say they have more chronic GERD symptoms, most of them tend to relapse within 1 year of discontinuing the therapy. So that's one thing you do want to know, is they may need to go back to it. So again, let them know that, hey, that's perfectly reasonable. Some patients need to. Again, if they have just mild disease, H2 blockers are fine. If it's more moderate, severe esophagitis, that's where PPIs are going to be more the mainstay of therapy there. If no questions, then we'll get into talking about the antiemetics. I'm sure I've probably caused some degree of nausea in most of you at some point during this class. Probably fair to say. Anyway, so our antiemetic drugs, we have quite a few different categories here, and we'll talk about how they're sort of useful, where they're going to be most beneficial for your patients. A lot of reason for your patients to be nauseous, right, and to have vomiting, right? Some of it may be related to GI bugs. Some of it could be related to motion sickness. Why do people get nauseous when they have motion sickness? Or like, what is it about the motion that causes that to occur? All right, so vestibular apparatus. So when your eyes are not matching up to what your ears are feeling. So for instance, one thing I've not done a lot of it, but virtual reality is one of those things where like you have like the big headset on and like you're finding movements occurring, like your eyes are seeing something that your vestibular apparatus is not feeling. That's where that dissyncing happens there, and you get really motion sick from that. But certainly things like cruise ships and things like that are another really big one, which is important too, because where are we at? Pretty close to the Space Coast, right? A lot of cruise ships heading out of there. But if you work in surgery, you're going to see a lot of post-operative nausea, vomiting, and then if you work in oncology, you'll find a ton of nausea, vomiting associated with chemotherapy. It's huge. You'll find patients, as I mentioned 2 weeks ago, maybe on 4 or 5 medications just for the nausea and vomiting associated with the chemo. There are more antiemetics than there are actual chemo drugs because it's so severe. Okay. Anyway, so why do we get nauseous? What are the different places where this actually is mediated? So we're going to find that some of this is going to be mediated through the stomach, right? We're going to have things like serotonin receptors. And when I say 5-HT, that is serotonin essentially, right? And there's a lot of variety of serotonin receptors we'll talk about. But anyway, so there's a lot of different neurotransmitters that are involved here. So serotonin is a big one that's going to be directly affecting the stomach. So you can actually have direct irritants on the stomach that can cause direct nausea and vomiting. A lot of this is going to be mediated through the CNS though, right? So you're going to find things like the chemoreceptor trigger zone, that CTZ, is another really big one. And if you notice the different types of receptors involved here, you're going to find serotonin. You're going to find D2 stands for what? Besides the best hockey movie of all time. Dopamine, right? So dopamine 2 receptors, and then also muscarinic receptors. We're going to find already there's several targets we can see here for our antiemetic drugs: dopamine, acetylcholine, serotonin. There's a vomiting center here in the medulla. The vestibular apparatus is going to be another big one. If you notice here, the H1 receptors can be involved with this, and we already mentioned earlier, sort of prophetically, that H1 antagonists can be used for nausea vomiting. We'll talk about why that is in just a little bit. So again, a lot of different targets here, and again, depending on the type of nausea vomiting you're dealing with, different drugs will be more better suited for that. Okay, also going to be a lot of side effects associated with these, as we'll see in a little bit. So anyway, so starting off with our antiemetic, or anti-muscarinic and antihistaminic drugs. So one of the big ones we have here, so for instance, is scopolamine. This is frequently given as a transdermal patch. Have you ever heard of like someone before they go on a cruise, a couple of days before, a couple of hours before, they'll put a little patch behind their ear? That's a transderm scope. That's a scopolamine patch. It's a direct anti-muscarinic. And so by applying that, they're able to actually help to inhibit that sort of signal from the vestibular apparatus. That way when you're on the boat, and even though it doesn't look like any motion's happening, but secretly you're kind of going like this, you're going to find that that is what's causing that this desynchronization occurring there, causing that nausea and vomiting. So this one, another big thing here as well, it's only applied every 3 days. So again, if you're on a 3-day cruise, a quick getaway, pop one of these on and you're good for the duration of that cruise, which is beneficial, right? Now, one thing to note, you gotta be really careful whenever you're dealing with topical medications like this, and make sure to wash your hands really good. So what do you think happened to this lady here? Rubbed her eye. Okay, so which eye is affected? You probably say it probably looks like her left eye is being affected here, right? And so why does her pupil look like that? Antimuscarinic, very good, right? So you're getting the antimuscarinic effect, just like we talked about their cycloplegics. If you go all the way back to ophthalmology, antimuscarinic drugs are going to cause mydriasis to occur. And so if you saw a patient look like that, apropos of nothing, and they just came into the ER and they look like that, you'd be like, oh no, I need a head CT like now because the patients have like a brain bleed, right? Not great. But if they're like, oh yeah, I just popped on a transderm scope, I didn't wash my hands, that's actually one thing that can occur there. So this is it was an interesting JAMA article. It was like, what is this presentation? And then they give you kind of limited history and you got to figure out what it is. Anyway, however, some things you want to know is that dry mouth, blurred vision, urinary retention can all occur because of that, right? So remember, what was our mnemonic we used for the anti-muscarinic effects? Dry as a bone, blind as a bat, mad as a hatter, red as a beet, hot as a match. What does it do to your heart rate? Tachycardia, right? So again, all those things you can see with that from those effects there. We actually started using a lot of scopolamine for some of our surgery patients. So we have these patients who are going in for scoliosis surgery, where it's a very intensive, long surgery, where they basically straighten out the entire spinal column using a lot of hardware and whatnot. And we actually give them transderm scope by actually using an antimuscarinic in addition to some of the other medications they give. It actually helps with sort of that, that sort of twilight, sort of amnestic sort of effects there. So you may see this used in surgery occasionally. Anyway, but the other agents you'll use more commonly are going to be your antihistaminic drugs. And remember, we're going to use first or second generation, do you think? First generation, right? Why would like cetirizine not be good as an antiemetic drug? Doesn't cross the blood-brain barrier. We mentioned that a lot of this nausea vomiting is related to central actions there. So by being able to cross that blood-brain barrier, you're going to find they can get into the CNS and have its effect there by blocking histamine receptors. Very good. So things like meclizine or antivert, right? What do you think it gets that name, antivert? Anti-vertigo, right? So again, it makes sense why you'd use this for motion sickness from that standpoint. But hydroxyzine, diphenhydramine, any of these would be totally fine from that standpoint. They all work equally well here. But big side effects are what? Sedation, right? So remember, if you're going to go on that cruise and you get motion sick and then you take a Benadryl for that and then you want to sleep the whole time, it's not going to be ideal, right? So again, there's drawbacks to everything. That's why transderm scope tends to be pretty popular for that indication. So other ways we can do is, well, what if we could block the serotonin receptors? It's 5-HT3 specific receptors, right? Now again, normally I don't get super in depth on the different types of receptors, if it's an M2 and M3, but certain cases we do, like beta 1, beta 2, things like that. This is another case with serotonin where you want to know your different receptor subtypes, and this will be more important next semester when we start to get into the neuro and the behavioral medicine, where we actually talk much more about the brain. But here you're going to find these are 5-HT3 receptor antagonists. And unfortunately, serotonin has like the highest number of different receptor subtypes. There's like 15 different ones there. But here we're going to have our ondansetron, which is like the gold standard nowadays, Zofran, antiemetic drug. And in fact, most patients that go into the ER, for the urgent care, probably going to get some Zofran, right? Even if they come in for nothing related, they say, oh, let's just give you Zofran anyway. We actually we have a set of nursing protocols we started in our ER to where if a patient comes in, they have a fever, well, the nurse doesn't have to wait for the provider to write the order. They can just give them some Tylenol. They can give them ibuprofen. And we actually added Zofran onto that, so that way the patient comes in, they're nauseous, we can go ahead and the nurse can say, okay, patient is a good candidate for Zofran, let's go ahead and order some. That's part of a protocol that they have there, but it just goes to show you how commonly we use it, that we had to put on this protocol just so a patient can get it on board sooner, so that way they feel a little bit better. Anyway, so on Dancitron, which is kind of the Mac Daddy, the gold standard, everyone gets that. Then you have a couple other ones like Dilasitron and Granicitron. These are more used for like chemotherapy-related nausea vomiting purposes. On Dancitron is like given like water basically out there in urgent cares and ERs. The nice thing about this is not only does it work centrally on those serotonin receptors up in the CNS, but also works down the stomach as well. So if you have any kind of direct irritants, it can help out with that additionally. Things to note, these drugs are very well tolerated, and in fact, I think some people kind of get a false sense of security when using Zofran to think it's got no side effects, but do be aware it can cause QT prolongation, right? And QT prolongation can lead to what? Torsades, right? And what's the treatment for that? Magnesium, very good. So be aware that by itself, yeah, it's probably not going to be a problem though, right? But who might it be a problem in? Maybe older people, right? If they have other drugs to prolong QT on board, or if they have a congenital prolonged QT, right? Sometimes that's not diagnosed, right, until they actually have an arrhythmia. But think about a patient, maybe they're on what class antiarrhythmic could prolong QT? So I think it's going to be on your test, right?
Yeah.
Perhaps. So class 3 more predominantly, because again, they're blocking those potassium channels. Class 1 can also do it a little bit. But again, if they're on, say, something like difetilide, and their QT is already prolonged, they're sitting at like, say, 480, 490, 500 maybe, and then you put on Zofran, that could be enough to tip them over, right? Those are things you have to consider there. So look at the past medical history, see if they're going to be a candidate for prolonged QT already, and then maybe not give them the Zofran, but that is a risk there. Okay. A couple of now we have our anti-dopaminergic drugs. So these are going to be blocking D2 receptors specifically. Dopamine's another one that has a lot of different receptor subtypes, but we'll talk about dopamine 2 receptors predominantly. And so we have drugs called metoclopramide or Reglan. This is probably the most common one out of this group here to be given. And then we have a couple of drugs from the category called phenothiazines. Now, phenothiazines are typically antipsychotic drugs, meaning we use them for what condition? Schizophrenia, right? So we'll talk much more about schizophrenia next semester. It's a very interesting talk, getting to diagnose a lot of your professors with different psychiatric conditions that we all develop. But the nice thing here is that one of the big problems with patients with schizophrenia is they have overstimulation of dopamine receptors, and that's what leads to a lot of the positive symptoms that they develop, things like auditory hallucinations, delusions of grandeur, all these different things here, right? You can kind of see where your teachers get it from. But by blocking those D2 receptors, that actually helps to decrease those schizophrenic symptoms. It's also helpful as an antiemetic sort of action here. So you have things like prochlorperazine or compazine. We give this all the time to patients with migraines, nausea vomiting related to migraines. Things like haloperidol or Haldol or promethazine or Phenergan, right? Keep in mind, these also have a lot of other actions like antimuscarinic actions, antihistaminic actions. These tend to be fairly sedating as well. I'll never forget this one time I was like really sick with some kind of GI bug or something, just feeling miserable, and my aunt had some, this was before I went to pharmacy school, so I didn't know this was not a great practice, but my aunt was like, oh, here, take some Phenergan, you'll feel much better. I said, okay, I'll take some Phenergan, and I slept for probably like 12 hours straight. It was the greatest sleep I'd ever had in my entire life, and will probably never achieve again since I've had children. But it was fantastic. I was totally dried out. Everything was all crusty because of all the antimuscarinic actions, but I felt great afterwards, much better rested. But just know that's a big side effect from these drugs here, okay? Some of the problems that you run into are the fact that by blocking dopamine 2 receptors, you can also cause some other sort of unintended effects here. So dopamine is really important as well for movement. And in fact, what type of patients have a lack of dopamine causing movement disorders? Parkinson's, yeah, we'll talk about that next semester as well. And actually, if you give too much of these kind of drugs, you can induce Parkinson-like symptoms, okay? So we call those extrapyramidal side effects that can occur there. So they have issues initiating movement, the pill rolling, tremor potentially. And in fact, before we had things like Zofran, I was talking to a hemonc pharmacist who's been practicing for a couple decades, and she was saying before we had Zofran, we used to give Reglan for all the chemo-related nausea, vomiting, and you had patients that were developed, they're on such high doses, they were basically looked like Parkinson's patients, but it was preferable to the nausea and vomiting they would receive from the chemotherapy. So when Zofran came around, it was like life-changing for a lot of those patients because they didn't have to rely on this. But for sort of short-term intermittent use, things like Reglan, things like promethazine can all be very beneficial for those patients. And in fact, a lot of our patients post-op, we'll have our anesthesiologist write their PACU orders, right? You know what PACU stands for? It's the post-anesthesia care unit. It's kind of where they come out of surgery, they get recovered, and then they get out to either outpatient or the floor or whatever. When the anesthesiologists are writing those PACU orders, they always write for an antiemetic drug, and probably half of them are writing for Zofran, the other half are writing for Reglan. So these are very commonly used medications there, at least on the pediatric side where I'm exposed to it most. Other things you'll find as well is that by blocking dopamine, you cause an increase in prolactin. You know what hyperprolactinemia can cause? Yeah, so it can cause things like gynecomastia in men potentially. It can cause issues of menstrual irregularities, because normally if you're nursing and you're feeding a baby, does your body want to get pregnant again? Right, it kind of shuts that down a little bit because you're trying to feed this other organism. You don't want to start growing another one in your own body, right? It's a very endearing term. And there's a very rare consequence of using dopamine antagonists called neuroleptic malignant syndrome. Just know it's a very severe complication that if not caught early can be fatal. We'll talk much more about that next semester. Just know that it's a side effect of these drugs in very rare instances. Okay, and then everyone's favorite, we have the cannabinoids. Cannabinoids are derivatives of cannabis, right? And so when looking at cannabis, what's kind of the primary psychoactive compound there? THC, right? I'm sure a lot of people have been hearing a lot about CBD as well as of late. What does CBD stand for? Cannabidiol, right? So those are the two main components there. You have THC and you have cannabidiol. THC stands for delta-9 tetrahydrocannabinol, if you're ever curious. And so when you're looking at the different actions, you're going to find that certain things, like for instance, CBD is really good for like seizure disorders. There's certain types of seizure disorders that are really managed well with that. THC is going to be better from the GI standpoint, right? And if you think about THC, like what's the kind of the typical stoner kind of effect that it'll have on the GI tract? You get the munchies, right? And so this is exactly what happens when we give some of our derivatives here. And so we'll just focus on the synthetic forms of THC that we actually have as FDA-approved products, right? Now, is there any FDA-approved THC products that's actually like made from cannabis? Currently, no, right? Because federally, cannabis is still a Schedule I substance. We do have one FDA-approved CBD product, and actually, it's actually for certain seizure disorders. But here we have synthetic versions of it, right? So we have dronabinol, and then we have nabilone. So Marinol and Sesamet, respectively. And so basically these are synthetic forms of THC, and we will find that these do have natural antiemetic actions, which is beneficial, but it's the appetite stimulation effects we really like as well. So for instance, if you have a patient who has chemotherapy, induced nausea, vomiting, they don't really want to eat a whole lot, they're losing weight, this is a really good set of drugs to give them to actually stimulate their appetite and put some weight back on, right? Any kind of muscle wasting disorders, if they have HIV/AIDS and they're losing weight, this is a good set of drugs to put them on to kind of help out with that, okay? Basically, will stimulate actions to kind of inhibit the vomiting center, but also stimulate the appetite. Very good from that standpoint. Now, because it is THC, you'll still find the psychoactive side effects there, so you can get a little bit of euphoria, they may get a little bit of confusion, etc. But the big thing is the increase in appetite is going to be kind of beneficial for them, for the most part. Now again, do you think these are a controlled substance or not? Yeah, these are still considered a controlled substance. I believe they're like a C4, C5, I have to double check, but it's a controlled substance. There's one thing to note there. Do you think pot is addictive? Some people are afraid to say no. Probably not, right? Like, if you look at the addictive potential of different medications, I think pot's probably on the very low end of the spectrum. Some more psychological addiction than it is more physical addiction. But again, we do still consider it a controlled substance, so we have to treat it as such, right? So that's one thing to kind of note with that. Now, do you think this would show up potentially on a urine drug screen? Yes, it can, right? So again, let your patients know that, hey, if you're going for a new job, if you need to get drug tested, you may show up positive for THC. You just have to provide documentation that, hey, I have this prescription, and then you're good to go, right? Because typically what they'll do is once they get a positive screen, they'll do a confirmatory test to see what it actually was in the system, and they'll go and check that out. But this can show positive for urine drug screen for THC, so you've got to be aware of that, okay? Let your patients know that, because otherwise it can be for a bit of a surprise, right? One time I was going for a urine drug screen, and I came out to hand the lady the cup, and I said, is it weird if it's purple when it comes out? She goes, what? Just kidding, it's fine. She didn't like that joke very much. Very serious about those urine drug screens. Anyway, the next group we have here is called substance P antagonists. You know what substance P is? Ever heard of it before? actually related a lot to pain. Actually, substance P actually can help this sensitize nerve endings to be more sensitive to pain. Or if you think about things like capsaicin, you find in hot peppers, this can actually stimulate substance P release, right? And we'll talk about capsaicin being used next semester when we talk about like pain conditions and whatnot. Capsaicin, where do you find that normally? Yeah, peppers, chili peppers, things like that, right? That's what causes them to be spicy. Anyway, so we have a substance P antagonist. You find that substance P actually can stimulate nausea and vomiting, and by inhibiting those receptors, you can inhibit that related nausea and vomiting. So here's a group of drugs, one called aprepitant, and basically this is being used for the delayed phase of nausea and vomiting. Some of these drugs like cisplatin, and cisplatin fell into which category of anti-neoplastics? It's an alkylator, right? So remember, alkylators are not very specific for any cell cycle. They're very bad in terms of their side effects, especially the nausea vomiting. So cisplatin can cause not only an acute nausea vomiting when they're actually getting the drug or in the preceding 24 hours, but there can be a delayed phase up to 3 days out. And so a lot of patients tend to get some nausea vomiting associated with that if they had that history of it. What we can basically do is give them a substance P antagonist. You still give them a serotonin antagonist like Zofran up front because that works for the initial phase, but you give them basically 3 days worth of aprepitant, and that will actually help to prevent that delayed phase of nausea and vomiting. So that can be very beneficial from that standpoint there. Okay, so we'll give it usually day 1, and then for the next 2 days afterwards, make sure they don't have that delayed phase there. Okay, be aware this does interact with CYP3A4. And so it can cause some interaction from that standpoint, so you want to be wary of that. And it does induce CYP2C9, so that can be a problem as well. So for instance, if a patient's taking warfarin, what would this do to their INR? Increase it or decrease it? Remember, think about the seesaw actions here. So if I induce CYP2C9, it means there's more of it. Warfarin levels are going to go down. So INR then goes down or up? Goes back down as well, right? Because again, less warfarin, less inhibition of vitamin K, more clotting factors being produced, INR goes back down to normal, right? Normal INR is 1, right? So again, you get a lower INR from that. Okay. So again, think about these interactions. You gotta sometimes just go through 2 or 3 steps of it, but think through that, and it should make sense. Okay, some other agents we'll give frequently includes our corticosteroids. So this is used quite frequently for nausea and vomiting induced by chemotherapy. So things like dexamethasone and prednisone. And how do we say these are good for certain types of cancers, the corticosteroids? Why might these be good? For like patients like leukemia, why might that be good? Mm-hmm. Yeah, it suppresses the white blood cells, right? So we can sometimes get double duty out of this. We'll find a lot of patients with ALL or different types of leukemia who will end up getting this for both purposes of nausea, vomiting, due to their chemotherapy they're getting, in addition to helping to suppress the white blood cell count. A little funny aside, so remember that roadmap that I showed you, the chemotherapy thing? I think that was an ALL roadmap if I recall. Anyway, I was talking to one of the other pharmacists. We were training someone up who's new, and she's asking about the roadmap. She's like, what does this mean, blah, blah, blah. And he goes, oh, this means it applies to all patients. And I was like, that doesn't mean it applies to all patients. It means it's ALL. It's like acute lymphocytic leukemia. He's like, oh, I never knew that. Sometimes it's funny, right? Abbreviations can be sometimes bothersome when in terms of like, what does this actually mean? You got to know what your abbreviations mean in those situations. Anywho, the corticosteroids, those are good from that standpoint. The benzodiazepines can also be used. So benzos, typically, anyone what we normally use these for? For anxiety, very frequently, right? For panic attacks. So we'll talk about the benzos next semester as well, but these are very good for sort of acute treatment, panic attacks, and help with anxiety. You'll find that these tend to be fairly sedating, so you do want to be careful from that standpoint. But this is good as an anxiolytic, meaning it helps to decrease anxiety. And remember I talked about that anticipatory vomiting you get sometimes with chemotherapy? Right, so if you recall that the last time you got chemo, that you got sick to your stomach, you felt miserable, then the next time before you get it, you may start to get kind of nauseous. This helps out a lot with that. So we can use things like lorazepam, which is otherwise known as Ativan, or alprazolam, which is Xanax, right? And we know that street name for Xanax? Bars? Yeah, bars. You know why they call them bars, or zany bars sometimes? Yeah, they come like, it looks like a little Tetris piece. You know that long Tetris piece? It looks kind of like that, and so you can kind of break them into quarters essentially. But they'll call them zany bars, things like that. Anywho. But yeah, so those are beneficial. It'll help to decrease some of that anxiety associated with it. That way they don't get that anticipatory nausea vomiting. Okay, so how should you choose an antiemetic? How do you know which one's good for your patient? It needs to be specific to that situation. So for instance, when you're looking at those chemotherapy roadmaps, they have that built into the plan to say, okay, what kind of antiemetics do they need? If they're getting something with a low emetogenic potential like vincristine, if that's all they're getting that day, then they'll go ahead and just get maybe a dose of Zofran, no problem. If they're getting something like doxorubicin plus cisplatin plus cyclophosphamide, or maybe a ARC or something like that instead, that's a pretty heavy-duty emetogenic regimen. They'll go ahead and they'll get aprepitant, they'll get dexamethasone, they'll get Zofran, they'll get diphenhydramine. They'll have all those on board because we do know that that risk is just so high there. But also consider the dosage form, right? So if you're nauseous, are you going to want to swallow a pill or a liquid? Maybe not in some cases there, right? So for instance, a lot of the Zofran that we have, it comes as an ODT. Anyone know what that stands for? It's an oral disintegrating tablet. You can actually just keep it in the mouth and allow it to dissolve, and that way you don't have to actually worry about swallowing the tablet itself. It'll just dissolve on its own, get absorbed, no problem. But we do have IV preparations that are available. Promethazine itself actually comes as a suppository, so you could do that rectally if you wanted to. So there's a lot of different routes that are available depending on the situation there, right? Just know that for motion sickness in particular, antimuscarinics are better suited for that. So that's where your first generation antihistamines and scopolamine come into play there. For just general acute nausea, vomiting, kind of just showing up at your ER, your urgent care, Zofran, your 5-HT receptor antagonists are going to be kind of your gold standard from that standpoint. So on the other side of that, we could do some prokinetic agents, things actually stimulating the GI tract. And so Reglan actually falls into this category as well. We talked about it as an antiemetic, but we can actually also use this to kind of stimulate motility in the GI tract. So if you have patients with, like, say, constipation, gastroparesis, where things are just not moving along, this can be beneficial from that standpoint. So this helps out with gastric emptying and whatnot. It can help out with GERD symptoms. So again, if they're holding on to a lot of food in the stomach and that's what's causing some of that reflux, this will help to kind of speed that along in those cases there. So again, just another use of that drug. Same side effects still apply as what we saw before. Another drug you may not think about, though, as being a prokinetic is actually erythromycin. It's a macrolide antibiotic. What's interesting is it actually stimulates these motilin receptors that are in the GI tract, right? So the GI tract gets stimulated by these receptors, and that will increase, actually it will start to decrease lower esophageal sphincter tone. It will decrease basically the transit time, so things will be moving through quicker. And again, that's why you end up seeing a lot of cramping, abdominal pain associated with erythromycin. It's because of that stimulation there, right? But we use this a lot for kids that have dysmotility issues pretty frequently. So if you see patients who are on erythromycin with no stop date on it, it's because you're using it for motility rather than using it for an actual infection. Okay, so I probably see this used maybe, I don't know, actual erythromycin used for an actual infection I've probably seen once in the past year, but all the time for motility issues, right? So it's a very common use for that. Yeah, you worry about some things like that, right? So maybe giving it with a probiotic or try to help them mitigate some of that. We know it's a risk, but it's one of those things where it's, you know, the benefits are outweighing the risk in those situations. Yeah. Okay. And then moving on, we have our laxatives. So this is a super common reason for people to show up in the ER urgent care, especially on the pediatric side of things. I'll never forget, my cousin called me up one time. His daughter, I think, was like 2 or 3 at the time. And he says, oh my gosh, she's having awful abdominal pain. I think she's going to die. We're heading to the ER right now. And I go, she's constipated. He's like, how do you know? You don't know that. And she's constipated. Sure enough, like 2 hours later, he goes, wow, they gave her an enema, and all of a sudden she pooped a whole bunch, and then she felt way better. And I said, yeah, she's constipated. Like, it's extremely common. Now, there's a lot of other reasons why patients may get constipated, but most of the time it tends to be diet related. So either patients are dehydrated, they don't have a good fiber in their diet, you know, a lot of different reasons though. But in terms of other comorbid conditions, things like hypercalcemia, heart failure, any of these things can decrease motility and lead to that impaction of feces there in the colon. In terms of drug-induced causes, this is another big thing you want to assess for in your patients, right? So for instance, opioids. This is a near almost 100% side effect of opioid medications is constipation, right? So that's why you always want to make sure you're giving regimens, laxative regimens to those patients to make sure that they will have movement of feces, otherwise you're just going to get super backed up. And in fact, when patients are withdrawing from opioids, we think is a common side effect of that. Diarrhea, because all of a sudden those opioid receptors not being hit anymore, all of a sudden peristalsis comes back. And so actually we had one patient in the ER, I'll never forget, on rounds, we had the environmental services people were cleaning up this one bay in the ER, and the attending was like, well, what happened here? And the resident says, well, I had a patient, I thought they were overdosed on an opioid, so I gave him a dose of Narcan. You guys are familiar with Narcan's the reversal agent for opioids. And he said, okay, well, what happened after that? He said, well, I didn't really have the response I wanted, so I gave him another dose of Narcan. And so, well, what happened then? It's like, well, then they got too big of a response, and then they had basically a code brown. And then they had to move the patient, get environmental services to come over, because the patient had been backed up for so long that basically it all came out at one time. So again, be aware of that as being an issue there. Other things though, anticholinergics, antacids, iron, calcium channel blockers, the list of drugs that cause constipation is pretty long. So be aware of that when you're trying to assess for those patients that are having that issue. So our goals here, one, we would like to make sure we reestablish kind of normal bowel habits and help relieve any kind of acute symptoms that they're having there. And obviously quality of life things are important. Now, a lot of times kids can develop sort of a psychogenic sort of constipation because they have a bad experience with it. They're scared of it. They're worried about pain, things like that. So they tend to hold it in until they get really backed up, really constipated, and that's when they get really bad abdominal pain associated with that. So that's another big issue we run into. But how do our laxatives work? Basically, there's a couple different things we can do. We can either increase the motility by directly stimulating the GI tract. We can try to increase the water content of the stool. So you ever see like those kind of those rabbit pellets that come out sometimes? They're really dehydrated and it's just kind of just real hard kind of stools. That's usually because they don't have a lot of water content to them. So we can have drugs that help to kind of increase that to try to make them a little bit softer, a little bit easier to pass. And then other things we can do is try to decrease colonic water and salt absorption. So by doing that, by decreasing reabsorption of water and salt in the colon, all that extra solute there in the colon stimulates peristalsis. The hyperosmotic sort of effect will stimulate peristalsis, stimulate defecation. We'll talk about medications that work through these different pathways. So when do we give patients laxatives? Well, if we're trying to prepare the bowel for surgery, right? So again, if someone's going for colonoscopy or if they're going for any kind of GI procedure where you want to make sure you clear everything out of the GI tract, this is where we'll do that. In some cases, we'll actually use certain laxative agents to try and increase excretion of toxins. And so for instance, I had a lithium overdose the other day, and lithium is a drug that is hard to clear from the GI tract. Things like charcoal don't really bind to it. And so sometimes you can give what we call whole bowel irrigation to try to basically flush everything out through the GI tract and then prevent absorption. So that's done occasionally. Post-operative stimulation. So we worry about things like post-operative ileus, especially in patients who are getting a lot of opioids post-operatively. And so you want to make sure the GI tract is waking up before you discharge them home. Actually, I had someone I knew. It was a girlfriend's dad or something from a long time ago. And he was talking about one time he actually had to have his appendix taken out when he's a little kid. And afterwards, he was always told that you don't pass gas in front of people because it's very rude. And so for a couple of days after the surgery, he was like really trying to hold everything in. He didn't want to let it go in front of the nurses. He didn't realize that the nurses were waiting for him to have a bowel movement or to pass gas, so that way they could show that the GI tract is working. And so he ended up extending his stay by like 2 or 3 days just because he was trying to be polite. So that's kind of cute, but anyway. And then obviously, things like minimizing, the strain of patients with cardiovascular disease, because again, if you're straining a lot, you're increasing cholinergic output, you can cause a lot of, vasovagal syncope, things like that. And then relief of temporary constipation. Those are the main reasons why you're going to give laxatives. Now, if you have underlying bowel disease, things like ulcerative colitis, things like Crohn's disease, those need to be managed first before you start to worry about giving laxatives in order to manage that. So, in terms of their general side effects, acutely you can find nausea, abdominal cramps, diarrhea associated with that, which makes sense, sort of over activity of the drug itself. Chronically, and this is a set of drugs you typically don't want to use chronically if you don't have to, because basically the body gets used to having those drugs around, sort of a physiologic dependence that can develop. And so you can find things like atrophy of the outer muscle layers, you can find disruption of normal flora. These things can happen to where they develop sort of this issue where they cannot really go without the effects of the drugs around and develops cathartic colon syndrome. So ideally short-term use if possible. We'll talk about which ones are better for more short-term use, ones that are better for more long-term use. So looking at the groups, as I mentioned, there's 3 main categories. So ones that help to soften the feces in about 1 to 3 days or so include bulk-forming agents, emollients, and then osmotic agents we'll talk about. We have ones that can actually directly stimulate the GI tract to cause peristalsis, and those are going to be our stimulant laxatives. And then those are going to cause sort of a watery evacuation, meaning you're going to get basically a flushing of everything out. It's going to include mostly your osmotic agents, some enemas, and then as I mentioned, the bowel cleanouts. We'll talk about agents that are good for that. So First off, the easiest ones you have, the bulk-forming laxatives. These are basically non-digestible fibers. This is like your Metamucils and your Citracels and things like that. Again, these are okay for patients to take every single day because this is probably supplementing the non-digestible fiber they're not getting in their diet otherwise, right? So a typical American diet, not a lot of non-digestible fibers, and so this is good to replace that. And basically what it's doing is increasing the bulk and the water content of the stool, making it easier to pass. And again, that bulk stretches those receptors and says, okay, we need to go ahead and defecate and get rid of this stuff. Be aware though that it will bind up to medication. So if they're taking their psyllium husk or whatever, they need to separate that out from their other medications, as we mentioned before. Can't see some cramping, some flatulence, but those are the main side effects. Very well tolerated. However, has anyone ever taken like a fiber supplement before or seen someone take it? How does it normally come? It comes as like a powder, right? And so it may not be very palatable to them, so you may need to find other dosage forms. So you can find like a big capsule that contains that powder. That may be a good alternative, but it's really kind of grainy, sort of not very palatable to a lot of patients. They may not want to take it because of that. Okay, next you have your stool softeners. These are actually, oh yes ma'am.
Do you take it, is there like a time frame you should take your other drugs, like before or after?
The same rule applies as what we talked about before. So either take other medications an hour before or 3 to 4 hours afterwards. Yep. Okay. Next are stool softeners. Will actually help to kind of emulsify the stool, make it a little bit easier to pass. You have things like mineral oil, things like glycerin, and then Docusate is probably the most common one. Docusate normally comes as like a tablet you can take there. And again, just will help to increase that water content, lubricate it, just make it easier to pass. So sometimes that stool gets really hard and very, very difficult to pass. It becomes painful. And so by making it a little bit softer, it's going to help to ease it a little bit easier for those patients there. Now the stimulants, these are things that you don't want to use for long term, mainly because the body gets very used to having that stimulant effect around, and such that when you take it away, they have a hard time sort of increasing defecation or causing defecation on their own. The two biggest ones in this category include senna and bisacodyl. Castor oil is kind of like a natural thing people have been using for forever, but the actual prescription products are senna and bisacodyl here. And again, they're going to directly stimulate that colon to cause defecation to occur there, right? As I mentioned, over the long term, we're going to find that will cause muscle weakness to occur, and the patient may not be able to stimulate defecation on their own. So again, shorter courses are always going to be beneficial. Now, one of the things you always hear, and I'll talk about this when we talk about pain management stuff, but whenever you have someone on a chronic opioid regimen, you always want to put them on a 2-drug regimen for their constipation. We call it mush and push. That sounds gross, but basically whenever you have someone who's on chronic opioids, we put them on a stool softener plus a stimulant laxative. So it's very common you might find a patient who is on senna plus Docusate together in order to help to cause that stool to be easier to pass and actually directly stimulate in and of itself. So if you ever hear that mush and push sort of analogy, that's what we're talking about there. So next we have our osmotic agents. So these are going to be typically taken orally, and this is going to increase the osmolarity of the contents of the GI tract. It's going to draw a lot of water into it, and that stretch, that increase in bulk is going to feel like, okay, the patient's got to go to the bathroom, right? And so this is where you have your mag sulfate, mag hydroxides. We talked about that earlier as being an antacid. If you ever see like a big bottle of milk magnesia, comes in a green bottle. They call it the green rocket. You know why that is? We should drink a bunch of it. You got to go to the bathroom like a rocket, so I'm going. But other things like lactulose, mannitol can be used here. Probably the more common ones you're going to run into as well include your sodium phosphates. These are what's known as your fleet enemas. So these are very common to give rectally in order to, again, increase the osmotic content in the rectum and in the distal colon, and again, stimulate defecation. Enemas are a very quick way to cause defecation to occur, usually within a few minutes to an hour or so. However, in terms of patient compliance, what do you think about enemas? Think it's something they like to do? No, and I had this one doc, he's kind of an old school guy, he would use enemas on basically everyone. So we'd have like teenagers coming in, like 15, 16-year-olds, and he's like, you're constipated, you're getting an enema. And they're like, not great. Like little kids, they don't care, like, they can't tell, right? However, you do have to be careful for some of these patients here because you can actually cause a significant hyperphosphatemia, which has led to death before, and it's typically going to be in patients on either extremes of age. So they're very, very young, so like infants are getting this. This is not a great, sodium phosphate is not a great drug to give to them. And the very elderly, especially with kidney disease, they may not be able to clear that phosphate very well. So it has led to death in some cases, and you have to be really careful with that. But fleet enemas can be very effective acutely. Another thing we'll give is also polyethylene glycol, which is your Miralax or Go Lightly. Okay, so kind of two different uses for that. These are oral agents. Now Miralax, It's a big deal when it became over the counter because that became kind of the de facto go-to sort of over the counter laxative agent. That Miralax, you typically take it, say 1 capsule a day. It's good for normal maintenance of defecation, right? You know, again, usually you should be stooling about 1 time a day. This is useful for helping out with that. Now, yes, ma'am.
So, I used to like work in the ER, and an ER doc once told me that if you're constipated, if you stick like a piece of a green onion like rectally, it will induce diarrhea. Is that true, or is that?
I've never tried it before.
I thought it was that. Yeah. Like a gallium.
If you'd like to run that as your research project for your master's, I certainly encourage you to try it. Where you'll find the volunteers, I don't know, but get the incoming first years. They won't know the difference. Okay, I have to do this. Yeah.
Well, I don't know. I didn't really go into detail. I just remember there's like a patient. He's like, "Oh, I can just do that." And I was like,
Did he just like go to the cafeteria and get a green onion, like, or did he just bring his own supply?
maybe? No, he didn't do it. He just said it.
Oh, you said you could do it.
Yeah.
Oh, okay.
Like you could. Like it would be like a home remedy, not to bring it in.
Not one I've heard of, but the number of things I don't know far exceeds the number of things I do know, so you could say. What does work, though, is polyethylene glycol, Miralax. Now, Miralax, as I mentioned, you can use it daily for sort of normal maintenance of defecation, but if you need to clean out the bowels very quickly, so say prepping for surgery, or if you have like a lithium overdose or something you need to clear out very quickly, that's where you have to go lightly, okay? Now, you notice the spelling Lyte, that actually refers to the electrolytes in it, because again, when you receive go lightly, there's nothing light about how you're going, okay? Because again, you're stimulating severe defecation, right? This is going to be coming out pretty watery diarrhea because it's just increasing a ton of water content. Has anyone ever seen a Go Lightly container? It's like a 4-liter container, right? So it has all these. It is what it is. Anyway, but it's a 4-liter container basically. It has this electrolyte powder at the bottom containing that the polyethylene glycol. The main thing why you include those electrolytes is because you don't want to cause any shifts to occur. You don't want to cause some patients to develop hyponatremia or any kind of electrolyte shifts to occur because of this extra volume you're giving them. And so, I mean, in some cases, like especially with like a lithium overdose, we can bump them up to like 2 liters an hour of this Go Lightly, right? 2 liters an hour. If you drink anything 2 liters an hour up, you're going to get sick, right? Again, so you get a lot of abdominal cramping, a lot of issues with that. But again, it's very good for evacuating everything out of the GI tract. Now, anyone know what the endpoint we look for what that is? Look for clear rectal effluent. That's the kind of the thing they talk about. Clear rectal effluent. Make sure you kind of get rid of everything out of that GI tract there, right? Now, one thing to know if you're taking Go Lightly, especially if you're like educating patients to take Go Lightly for like a bowel prep or something, sometimes they'll have them mix it into something like Gatorade or something like that. What color should you avoid of Gatorade? Red, right? Because what does that look like? Looks like bleeding, right? So you don't want to do that. You don't want to go in for your colonoscopy and think there's a bunch of blood around when there's really not. So that's one thing to note with that. Sometimes what we'll do in terms of if I have patients who have receiving Go Lightly for whole bowel irrigation for like a lithium overdose, as I mentioned, we'll actually give them charcoal beforehand. Charcoal binds up to a lot of medications, and so we'll give them that first, and then we'll give them Go Lightly behind it, and now actually we can bind up any medications that might be there in the GI tract and then flush them right out. And so we actually call that, we'll sometimes call it Go Darkly, because that way they have the charcoal first coming out, and then they have the Go Lightly kind of flushing the rest of everything out. So that's sometimes a tactic we'll use there. Again, remember, anytime you have a neutropenic patient, you don't want to give them anything rectally. Why is that? Talked about it last week. Right, because remember when you're receiving chemotherapy, that GI epithelial tissue becomes friable, right? It becomes more brittle, and it's easier to cause a puncture through there or a break in that tissue, and that can introduce bacteria, especially from the rectum, right? So no DREs, no rectally administered enemas, nothing like that. Yes, ma'am.
So is Go Lightly the one that you wouldn't want to use if you have a young patient or an old patient?
So those are okay, actually, because of the way that it's balanced. Like you don't really cause the Fleet's enema is like all just sodium phosphate, so it's a ton of phosphate there. Patients can absorb. With the Go Lightly, that polyethylene glycol mixed with those electrolytes shouldn't really cause any significant shifts. So those are safe to use in those cases there. And so for a lot of like pediatric patients, I'll find that they just mix a scoopful of Miralax into their their juice or the water or whatever, and it's like pretty tasteless, and so they can just get that in and pretty good for maintenance. Yeah. Okay, but as I mentioned, be careful. The sodium phosphate has caused fatalities before. Okay, so again, obviously, with a patient with constipation, you want to fix the underlying cause if possible. So if it's medication based, try to get rid of that medication or switch to something else. The dietary modifications are going to be the best thing for them long term, right? Getting more water into their system, getting more fiber into their system, and then initially, especially if you don't need to treat anything sort of acutely, try an osmotic laxative, try some Miralax, try an emollient like DocuSay. Try 2 to 4 weeks or so. See how they respond to it. Typically, if they don't have a bowel movement for about 2 days or so, that's where you can use sort of an as-needed stimulant like Senna, like Bisacodyl, for sort of temporary relief. But again, you don't want to use that chronically if you don't have to. Now, in some cases, we'll actually use opioid receptor antagonists for patients who are on opioids, and so there's actually a couple we'll give that actually just work on the GI tract and don't actually get up in the brain. We'll talk about that next semester. And then again, for evacuation of the bowels, that's where we use our osmotic enemas, or we use like Go Lightly. I should be giving it either through orally or through an NG tube or something like that. But again, avoid those phosphate enemas in the young and the old. So on the flip side, let's look at some anti-diarrheal agents here. So these help to enhance water absorption and they'll decrease GI motility locally. And so the two main categories we have here are a couple of opioids actually. And we said opioids cause constipation. These drugs do the same thing. They just don't cross the blood-brain barriers. That way they don't actually cause any of that euphoria or analgesia. They just work on the GI tract. And so these include diphenoxylate and then loperamide. Okay. Diphenoxylate actually is compounded with atropine. What's interesting here with atropine is that it's not absorbed orally. However, what patients used to do back in the day is they would actually crush up these diphenoxylate low-modal tablets and inject it. And by injecting, they got a much higher bioavailability and they actually find some euphoria with that. But by combining with the atropine, you get so sick from the anticholinergic poisoning, they didn't want to do it. So that's the reason why they include that there. And then loperamide. Obviously, the adverse effects are going to include constipation, exaggerated GI effects, abdominal cramping, etc. You can develop this megacolon, so we don't recommend long-term use of this, mainly because especially if they're treating some underlying condition that needs to be managed, they can end up holding on to stuff they don't need to, especially like infectious cases. You really want to get rid of those bacteria, right? You don't want to hold on to that. So these are not going to be recommended routinely, but for occasional use, it may be okay. Bismuth is also good as an antidiarrheal, not just as a gastroprotectant. Be aware though, this is going to be good for like infectious types of diarrhea. So like traveler's diarrhea is a very common agent you'll give for those patients there. Just be aware of the bismuth issue along with the salicylate issue in terms of your patients. And I believe that's it. If you have any questions, well, it's kind of quick, but I want to make sure we covered everything before the final. Any questions on the other sections we've covered? Any burning things you've been thinking about? So I'll try to be responsive to your emails. I want to try to get everything graded by this weekend, so that way you'll kind of know what you're heading into in terms of the final. If not this weekend, by Monday, Tuesday, I'll probably have all the prescriptions done. Anything else? Any other things I forgot about? Sure. I mean, that's not a necessary thing to include in all your prescriptions unless you really want them to take it with or without. But if it's with or without, it's like, I just don't even write it on there. Remember, you have limited real estate, so to speak, on those medication labels. The more stuff you put on there, the more kind of blind the patients will get to it, and they'll kind of gloss over stuff.
And then the last one, the Zantac and the R word.
Ranitidine? Ranitidine? No?
Do you shake it while it's a suspension, or?
What do you guys think? Actually comes as a syrup, yeah. But if you do have suspension, you can put shake well in there. That's fine. It's reasonable. But yeah, check your dosage form. That one does come as a syrup. So, homogeneous solution. Anything else? So you don't have to. You can take it kind of whenever. Because again, if you're using it for more prophylactic use, then it doesn't really matter if you take it with food or not. Yeah. Yeah. So Pharm 2 will be next semester. It's more of the same. It's just different subjects. So if you're kind of used to what this is now, it'll just be more of that, just different topics. But if nothing else, I guess I'll see you guys next semester.